Facial weakness is a very common disorder you may encounter during your clinical practice. It is also very common spot in OSCE exam at the end of round training and a standard point in the multiple choice questions either at the end of round or end of year exam. So let us explain the hidden points in facial palsy and identify the best way to answer questions regarding this point. When you are confronted with a case of facial weakness, you have three questions to answer. Number one, is it a facial weakness? Number two, is it upper motor neuron or lower motor neuron facial weakness? Number three, if lower motor neuron, can you localize the lesion? So, number one is it facial weakness? Can it be something like it? Yes, it can be psychogenic facial deviation. So how to differentiate between true facial weakness and psychogenic facial deviation? By contracting the platysma muscle. Anyone cannot soundly contract one side only of the platysma muscle. You have to contract both sides together. We ask the patient to contract the platysma muscle by stretching the skin of the neck, like this. If the patient has psychogenic facial deviation, both sides will contract symmetrically. But if the patient has organic lower motor neuron facial, one side only will contract, differentiating between psychogenic and true organic facial weakness. Then the second question, is it upper motor neuron facial or lower motor neuron facial? To illustrate this point, we need to understand some simple facts. Number one, upper motor neuron facial affects only the lower part of the face. If we look to this picture, the fibers supplying the upper face are in violet, while those supplying in the lower face are in green. If we have upper motor neuron lesion like that on the right side, the green is completely interrupted, so the lower face is deviated, but the violet is interrupted only on one side, sparing the other side of the upper face, which receives this ipsilateral violet supply with no affection. So we call this upper face sparing in upper motor neuron facial weakness. Only the lower half of the face is affected. Similarly, the emotional fibers are spared in upper motor neuron lesions due to bilateral supply. Let me explain. We have two types of fibers controlling the facial muscle movement. Those of voluntary control, like those in green, and those of emotional control, like those in violet. Basically, the voluntary control takes the upper hand. If the patient with upper motor neuron facial uses the voluntary control, this will lead to deviation of the mouth to the opposite side of the facial weakness. On telling the patient a joke, some of the muscles under the emotional control will get some supply from the ipsilateral emotional fibers in violet, leading to some correction of the deviation. But in lower motor neuron facial, both the green and the violet are affected at the final common pathway, leading to deviation initially that increases on telling the patient a joke due to contraction of the contralateral unopposed muscles of emotional expression. The third difference between upper motor neuron and lower motor neuron lesion is present only if the facial weakness is associated with hemiparesis or hemiplegia. First, we need to know that we have corticobulbar tracts that crosses the midline just before its relay in the motor nucleus of the corresponding cranial nerve. In case of the facial nerve, this will be in the pons. In addition, we have corticospinal tracts that crosses the midline in the lower part of the medulla. This is the right and this is the left. If we have an upper motor neuron lesion here in the motor cortex, this will affect both corticospinal tracts and corticobulbar tracts. On the right side, leading to contralateral left hemiparesis and contralateral left upper motor neuron facial. So both the facial weakness and the hemiparesis will be on the same side. If the lesion is on the right side of the pons, this will affect the motor nucleus of the facial nerve, giving right lower motor neuron facial weakness. In addition, the lesion will interrupt the corticospinal tracts that will later cross the midline in the medulla, supplying the motor control over the left side of the body, giving left hemiparesis. In this case, we have right lower motor neuron facial and left hemiparesis. So the lower motor neuron facial weakness is on the opposite side of the hemiparesis. Let us shift to the third question. If lower motor neuron fascia, where is the lesion? To understand this, we need to revise the anatomy of the lower motor neuron fascia. Okay, let's start. The facial nucleus lies in the pons and is surrounded by other nuclei of the cranial nerves like abducent nucleus. Even more, many tracts pass nearby this nucleus, including the spinocerebellar tracts, pyramidal tracts, and the spinothalamic tracts. So if we have pontine lesion affecting the facial nucleus, this will definitely be accompanied by other cranial nerve affection, in addition to tract affection, giving ipsilateral cerebellar signs or contralateral hemiparesis, etc. according to the tracts. After leaving the pons, the facial nerve passes through the subarachnoid space. At this point, it will be accompanied by the 8th cranial nerve, which is the vestibulocochlear, and the 5th cranial nerve, which is the trigeminal nerve. So lesions at this point, like cerebromontine angle tumor or postmeningitic arachnoiditis, will lead to affection of these cranial nerves, in particular in addition to the lower motor neuron facial weakness. Then the facial nerve passes through the internal auditory canal, which is graded in blue. Through this canal, it will be accompanied only by the 8th cranial nerve. So if the patient has a history of fracture base of the skull, middle cranial fossa, after head trauma, or had the chronic middle ear infection like cholesteatoma, either of them may interrupt the facial nerve inside the canal, leading to lower motor neuron fascia, in addition to the vestibulocochlear nerve affection. After going out of the canal, it relays in the geniculate ganglion, where it divides into two major divisions. Anterior one, called greater superficial petrosal nerve, which is secretory and concerned with lacrimation. By the way, these fibers of the greater superficial petrosal nerve are the only fibers that don't relay in the geniculate ganglion. So if lesions of the geniculate ganglion, like herpes zoster, for example, this patient will not have affection of lacrimation. The posterior part, which is the main division of the cranial nerve, will pass through the lateral wall of the middle ear to give two main branches. One of them is small, which is nerve to stapedius. This muscle is concerned with damping high-pitched loud sound. And by the way, if this is affected, the patient will complain that loud sounds are painful for him. and we call this hyperacusis. The other large branch is called the chorda tympani, which is partially secretory to the salivary glands and mainly carries taste sensation from the anterior two-thirds of the tongue. So lesions of the middle ear will affect all the external muscles supplied by the facial nerve, in addition to the chorda tympani with or without hyperacusis. Then the facial nerve comes out of the middle ear through the stylomastoid foramen. So lesions at the stylomastoid foramen will not affect the taste or the secretory fibers. Let us revise. If we have lesion in the bones, we shall have lower part of the face affected, upper part of the face affected, platysma is affected, loss of taste of the anterior two-thirds of the tongue on the side, loss of salivation on the side, hyperacusis, loss of lacrimation, with or without abducent nerve, if the abducent nucleus is affected, with or without long tract affection, like ipsilateral cerebellar signs, contralateral pyramidal signs, contralateral spinothalamic tracts, pain and temperature. And if the lesion is in the subarachnoid space, we shall have lower part of the face affected, upper part of the face affected, platysma positive, loss of taste of the anterior two-thirds of the tongue, loss of salivation on that side, hyperacusis, loss of lacrimation on that side, with or without affection of the vestibulocochlear nerve, and with or without affection of the trigeminal nerve. Lesions of the internal auditory canal will have lower face affected, upper face affected, platysma affected, loss of taste of the anterior two-thirds of the tongue, loss of salivation on that side, hyperacusis, loss of lacrimation with or without vestibulocochlear affection, mostly with. If the lesion is in the geniculate ganglion, like herpes zoster, as I told you in the previous section, so lower part of the face will be affected, upper part of the face will be affected, platysma will be affected, loss of taste of the anterior two-thirds of the tongue, loss of salivation on that side, hyperacusis without affection of lacrimation. If the lesion is in the middle ear, lower part of the face will be affected, upper part of the face will be affected, platysma will be affected, loss of taste of the anterior two-thirds of the tongue, loss of salivation with or without hyperacusis. If the lesion is in the stylomastoid foramen, like Bell's palsy, which is the most common type, we shall have only lower face and upper face affection, in addition to the platysma sign with the sparing of all other functions. So how to examine for the facial nails? So examination of the facial nails is very important. This is the clinical part you will be asked for in the exam. So when you are asked this question, you will answer as follows. First, by inspection, we shall observe for asymmetry in the width of the palpebral fissure. We shall observe the asymmetry of the wrinkles of the forehead. We shall observe the asymmetry of the nasolabial fold. If they are flattened on one side, for example, this indicates facial weakness. Deviation of the angle of the mouth to one side, usually the side opposite to the weakness. So observation is of 4 points. Then we shall examine for the muscles of voluntary control by asking the patient to perform some motor tasks. We divide the muscles under voluntary control into 2 groups. One group for the upper face and the other group for the lower face. For the upper face, we have the frontalis muscle. It is examined by asking the patient to elevate the eyebrows. Then we have the corrugator muscle, which is examined by asking the patient to frown. Then we have the orbicularis oculi. It is examined by asking the patient to close his eyes forcefully. They are symmetrical. We can try to gently open the eyelids and feel the difference in resisting the power between the 2 sides. Then we have the other group, which is the muscles of the lower half of the face, and they include zygomaticus, which is examined by asking the patient to show his teeth. vaccinator, which is examined by asking the patient to blow, and orbicularis oris, which is examined by asking the patient to purse or whistle. After this, we need to examine for the emotional fibers. In patients with facial deviation only, we can test the emotional fibers by telling the patient a joke. If more deviation is noticed, this means that he or she has lower motor neuron facial. Then we examine the taste sensation in the anterior two-thirds of the tongue, once on the right side and then on the left side. We bring 3 test tubes. Each of them contains solution. Number 1, sweety one. Number 2, salty one. Number 3, bitter one. We tell the patient that he or she will taste it either sweety, salty, or bitter. And we have a deal with the patient. If sweety, please put your thumb up. If salty, put your thumb down. And if bitter, put your thumb on the side. Then ask the patient to protrude his tongue and dry the dorsum of the tongue with a paper tissue. Then instill drops of the solution number 1 and look at the reaction of the patient. If he puts his thumb up, this is correct and he has normal taste sensation, etc. Then lacrimation. Lacrimation is tested by Schremer test, and you have studied it in full details in the ophthalmology department. By this we end the last part of facial nerve examination, wishing you the best of luck. Thank you.